Hello everyone, good morning and welcome to the inaugural webinar of the TRIPOM webinar breakfast series. We're just waiting for a few more attendees to arrive. I can see a few more flooding in, which is nice to see. And thank you very much for coming and joining us on a lovely Saturday morning. As I said, I'll give it a couple more minutes to try and allow a few more attendees to arrive, and then we'll get going with the presentations. Lovely. So the attendees are still coming in. Give it a couple minutes or so. And thanks again for everyone who's just arriving for spending an hour and a half or so delving into the world of perioperative care. Lovely. So I think we will get going. Welcome everyone to the inaugural webinar of the TRIPOM webinar breakfast series, Perioperative Care Update, Challenges and Solutions in a COVID-19 Era. It's an absolute pleasure to welcome so many of you onto this exciting platform, and I hope you will get a lot out of today's session and from the sessions over the next couple of weeks. We have a plethora of speaker talent delivering cutting-edge talks from the world of perioperative medicine, all of which will give a fantastic insight into some of the developments, challenges, and solutions relating to perioperative medicine in the shadow of COVID-19. Please do use the Ask Question function that you should have access to from whichever device you're joining us from. We will be taking questions. These can be asked during the presentations, and we'll try and filter through as many as we can and try and ask at least 3 to the presenters. So to begin with, I'd like to hand the stage straight over to Cyril and Faye.
Cyril Fox. Well, actually, when I started, I was a bit short of breath. So I went and seen the doctor, and she took a blood test, and she found out I got prostate cancer. I felt all right. I didn't feel as though there was anything wrong. When I went and seen the doctor about the breathlessness, I thought that's all it was. Oh yeah, I had this active thing on the wrist.
To know
to know what I was doing.
Activity.
Yes. She just checked it, that was all I was getting on.
All the activity, whether it was small or a large activity, which showed on the chart. And she was just saying they wanted to get him fit for the operation.
And she was pleased with that, weren't you?
Yeah. And also, I might just add that we were given a diet, a food diet also, to build him up for the operation. But we knew that people's lives were in danger, so they had to be looked after and treated. So I think that was, one of the reasons it perhaps was just put on hold for a while. I understand from the news that the operations were not going ahead because they were so busy with the pandemic. We understood that, so it was more important, you know, to do that, to save lives at that time.
Huge thanks there to Cyril and Faye for providing some proper context for our webinar. Someone may have their turned off, that'd be great. Lovely. A huge thank you to Cyril and Faye for providing apologies there. I said it. Thank you to Cyril and Faye for providing some proper context for our webinar this morning and some great insight into Cyril's cancer surgery journey. I believe they've tuned in this morning. So hello, Cyril, and hello, Faye. Now, our first talk will be delivered by Professor Sandy Jack. Sandy is a professor of prehabilitation medicine at the University of Southampton, consultant clinician scientist at University Hospital Southampton NHS Foundation Trust, and chief investigator of the WESFIT and SafeFit trials, which are pioneering implementable multimodal prehabilitation in a COVID world. Just a few days ago, they won the HSJ Cancer Care Initiative of the Year. So congratulations, and over to you, Sandy.
Thank you very much, Johnny. The HSJ was very unexpected. Congratulations to everybody, and thank you so much to the team and all the support. Welcome to thank you for inviting me to speak at this inaugural TRIPOM webinar, and hello everybody. So I'm going to just talk about briefly some key findings just to set the scene. Talk a little bit about WESFIT and remind people about what that is all about, and then moreover talk and concentrate on SafeFit, the challenges, the barriers, and how we've delivered this, and then a summary. So just a reminder to say that we and others have found that cancer treatments affect your physical fitness. And we performed this trial looking at the effects of neoadjuvant chemo and chemoradiotherapy on exercise capacity and outcome in esophageal and gastric cancer patients. And we looked at the physical fitness using cardiopulmonary exercise testing prior to having neoadjuvant chemo treatments. And then we waited 4 weeks after they completed their cancer treatments. So this wasn't an acute toxic effect, this was a more chronic toxic effect, and saw that the VO2 at anaerobic threshold decreased significantly, and this was clinically as well as statistically significant. Moreover, the Kaplan-Meier plot here shows that Kaplan-Meier plot here shows that not only did, sorry, I'm having technical problems, not only did the physical fitness decrease, but the dual insult of surgery and cancer treatments affected people's survival rates. So the people that had the highest or higher compared to the lowest or lower risk 12-month survival had a fourfold increase in mortality. So the highest and higher group had fourfold increase in their mortality rates at 12 months. So we looked at whether we could reverse, ameliorate, or at least address the effects of chemo and chemoradiotherapy and the toxic effects. And this was a trial in rectal cancer patients, and we delivered this following neoadjuvant chemoradiotherapy. And this was a 6-week exercise training program that was delivered 3 times a week using HIIT training. We saw in the control group in the bold and the exercise group in the dashed lines that was significant fall in their physical fitness. And this was, again, clinically significant as well as statistically significant. And moreover, people that were at the beginning, before they had their chemo rad, were a lower risk and would only need a ward bed. And now, after their chemo rad, they are at higher risk and would need more intense post-operative and perioperative care. We saw that after 3 weeks, there's a significant increase in physical fitness, so you don't need a particularly long training program to be able to do this. And that at 6 weeks, they had returned to way above their baseline. And the control group actually fell to the same level after chemoradiotherapy, but then continued to fall. And at week 14, when we followed up the patients, so we stopped the training program at week 6 and followed them up at week 14, that they'd fallen significantly. If we just ask people to increase their physical activity, and that's different than physical fitness, then there was no difference in step count. So actually, a training program is key to be able to improve people's physical fitness prior to surgery. So we also looked at tumour regression, and we looked to see if there was a significant difference between the exercise group and the control group in MRTRG and histopath. We saw that there was a favourable outcome of 22% in the control group compared to 58% in the exercise group. So that actually, although hypothesis generating, that physical fitness and HIIT training may downstage tumours. And this was statistically significant in the exercise versus control, but moreover, more highly statistically significant if we looked at whether people responded to a training program and responded to their chemo rad. So this all leads on to how we developed WestFit and SafeFit. So based on the comprehensive model of personalised care and the government advice to look at universal, targeted and specialist. Universal in their language is just advice, and targeted, whether we're talking about the population or the interventions, or in people with physical or mental conditions, and the specialists are 5% at the top of complex needs. So I was very lucky to co-chair the Prehabilitation for People with Cancer guidance, which was hosted by Macmillan and Royal College of Anaesthetists and the NIHR Cancer Collaborative, Nutrition Collaborative. We looked at screening, assessment and intervention, and moreover monitoring and evaluation is really important to be able to deliver these data in these trials, to be able to then evaluate and provide the evidence required for NHS England or the commissioners to really start to understand the benefits and commission these services as business as usual. So this is how we then looked at our model of personalised care translated into the Macmillan guidance, and the universal, targeted and specialist shown here. There are actually 64 combinations of this triangle, and actually the more we think about it and the more I've learned over the last few months with SafeFit is that it's more like a rotating Rubik cube. You can have 64 combinations because of all the interventions, including behaviour change, and that you can go up and down this triangle, and you can have universal for one of the interventions, so nutrition, exercise, targeted and specialist for psychological support. So it's a lot more complex, and there's even more complexity in that we found that you could have hard universal, so supported management with advice, and soft targeted, which home-based but supervised training, which is effectively what SafeFit is. So WestFit's funded by NHS England, and it's by the Cancer Transformation Programme through the STP. We got this £2.3 million grant on top of the recovery package, which is mandated by Macmillan and the government, which is a soft touch prehabilitation package. It's Wessex Fit for Cancer Surgery trial, and it's a pragmatic factorial design randomised control trial to assess the efficacy of the implementation of prehab programme in patients undergoing a major elective cancer surgery. And this is the big 5, which is upper GI, lower GI, thoracic, urology, HPB, and we also shoot in head and neck because these patients desperately needed some support. The flow diagram shown here is male or female patients aged over 18 years with planned treatment with or without cancer treatments neoadjuvantly. We screen along the surgical pathway. We then screen the patients with CPET, and then if there are no contraindications, they're then randomized to either control, which is standard care, or optimal standard care, exercise, psychological support, and exercise plus psychological support. And then they have surgery as planned with no delays, and then post-operative follow-up. The infographic here shows this in more detail. So prior to surgery, we assess the patients with cardiopulmonary exercise tests. The minimal pathway is 2 weeks, and that's around the most of the people that are on Westfit, or 3 weeks if we're lucky because of all the targets and breach issues, and 15 weeks if they're undergoing cancer treatments. We then do their cardiopulmonary exercise test prior to surgery and post-surgery at week 12. The control group, say, is standard care with extra monitoring. Exercise is performed in the community gym, and we also deliver healthy conversations, and this is by personal trainers. Psychological support is non-directive counselling in wellbeing centres, and the combination of exercise, psychological support and healthy conversations in group 4 is what we hope would be commissioned with the addition of nutritional support also. So this is being delivered, or was being delivered, across 10 gyms in Wessex and 4 cancer support centres. It was highly successful in that people really appreciated that they didn't have to pay for parking, and they could go to someone close to their homes and be delivered by a same personal trainer and the same rigour of the interventions that would have been delivered in hospital. We're also lucky that this has been adoption and spread across the UK, that there are 19 alliances, and we've been contacted by 17 of those alliances wanting to take part in Westfit. So unfortunately, before lockdown, we made the decision to pause Westfit. So we actually paused it before we were told to, and we had to ring up 9 patients that were on the trial, and they were completely devastated that we would no longer be able to have this support, particularly with COVID looming, and they felt very isolated. And at that point, they said they'd rather risk the dreaded lurgy than not be able to have the support to get fit for cancer surgery. I'm sure they didn't, and none of us really realised how dreaded the lurgy is, but it clearly had a significant effect on them and me. I thought, I can't just sit back and do nothing. So I text June Davis, who's the lead for the Macmillan Guidance, and chaired this with Mike Grocott. And within 4 weeks, we set up virtual clinics to deliver what we thought were universal interventions to maintain mental and physical health in people with cancer, following social distancing, and also this is a COVID-19 targeted trial. The graphic here shows that how we SafeFit process happens. We were funded initially by Macmillan, and the self-referral was open on their website. We were completely inundated with referrals, and we had over 100 referrals within the first couple of weeks. We were lucky that the personal trainers, these Can Rehab personal trainers, said that they would give the first month for free, but we also had to do a lot of additional training, which I'll go into in more detail. So this is not as simple as it first seems. So we are very pleased to announce that SafeFit now is on the portfolio, and we have excess treatment costs to pay for and deliver the interventions. So we are changing how we're going to deliver this, because it needed to be more robust and less complex with lots of partners. So they will have self-referral, or via MDT or clinical referral. We will then screen and assess the patients for eligibility, and then inform consent, complete baseline, allocate to interventions, and match those to an appropriate personal trainer with, if patients need a specific need of any cardiac issues, psychological issues, or nutritional issues. The sessions first month are delivered between 1 and 3, so maximum of 3 per week with the instructor, and then months 2 to 3, then it's once per week. We complete the questionnaires at the end of month 3, and then month 4 to 6 it is 1 session per month and then follow up, and we deliver the interventions through the course of 6 months. We set this up to deliver a program of physical activity sessions, which we actually now have discovered that this is more soft targeted because it's supervised home base, supported to optimize nutrition and psychological support with resources and apps. It's available for anyone with cancer in the UK with a suspicion of or a confirmed diagnosis, but does not require histopath. There's a rigorous screening assessment process throughout, which is essential, particularly because I decided to call the trial SafeIt, so we had to make sure the rigour was there. And just to say that the rigour of a clinical trial with the infrastructure and the support of a clinical team is essential, and this could not have been set up as a service without that rigour. It's 6 months of personalised support from the CAN Rehab instructors that we had to train. These are essentially exercise instructors, and we had to train them in the other aspects of prehabilitation. It's a 6-month training programme and it's titrated. This is because behaviour changes are predominantly our aim, and it needs to be more intense at the beginning and followed up for 6 months. It's delivered by telephone, video conferencing combination and in group sessions, and we had to check for COVID status throughout. The additional training are healthy conversations and making every contact count, and enabling and briefing client-based empowering interventions and social cognitive theory. Webinar with supportive materials. We also had the input from a clinical psychologist that set up the escalation plans. We focus on key communication and recognition of emotions, active listening, and also following the NICE guidance for psychological support. With generic nutritional principles in line with recommendations from the World Cancer Research Fund and the BDA, working with the participants for their own diet and pointing them, directing them and signposting them to the recommendations to enable goal setting, and in principles just advising healthy eating and being able to screen for any incidences of overt disease-related malnutrition. So the inclusion criteria is male or female participants over the age of 18, as I said already, suspicion of cancer. The only exclusion criteria per se is for the whole trial is unable to give informed consent. This is because we decided that in this pandemic that the patients could have just one of the interventions, but they would be excluded from the other 2 interventions or one of the other interventions if they're contraindications. Sample size is 1,100 with 20% dropout, with the groups divided into confirmed, suspected, self-isolating or none of the COVID-19. The clinical escalation plans are that we screen patients for COVID throughout the whole of the trial, and that if they have any indications that they have COVID, they either do not start their exercise or pause for 14 days on the advice of the clinic, of our clinical support, due to the fact that COVID is related to cardiomyopathy. We screen between each session, before each session, and we look at nutrition assessments questionnaires. If they score over greater than or equal to 9 on the patient-generated subjective global assessment, then we escalate to a dietitian or back to their GPs. And psychological and mental health considerations we fit with an algorithm. So we use these distress thermometers or emotion thermometers. If they score more than 8 on the distress thermometer, we escalate. The biggest concern was self-harm, so self-reported dementia and Alzheimer's. If people score greater than 8, then we go through the algorithm and check whether the self-harm, whether they've actually thought about this and plan to do this, and we escalate appropriately. If there's no indication of actual intent to self-harm, we give the advice that they go to a personal trainer with mental health. So primary objective is to investigate the efficacy of remote multimodal universal interventions via virtual clinics to improve physical fitness or function as measured by a subscale of the EORTC. Then we look at patient activation measures, behaviour change and effect on health economics, and our exploratory outcomes are overall survival and adherence and intervention advice. We opened on the 25th of May, first patient recruited within 3 days, and amazing feedback, and have continued to have amazing feedback throughout. The first patient we actually spoke to said she was feeling very low, and she even did her hair for the call despite not being able to see her. We've had feedback to say that not only are the patients doing this, but all of their families are joining in, and it's very clear the effect of COVID on mental health. So guidelines and position papers, where are we and whether we can set this up as a service or not? I think quite a long way. Some of our preliminary cost effectiveness has looked at overall saving of length of stay in a handful of patients, and there's some indication that 30-day readmission rates, we saved 2,700. Of course, in addition, there's all the patient benefits, but we worked out the total cost of Westfit per se is around 120 per patient. We also want to look at, if you're going to look at a service, that host and tumour phenotyping, so stage the host and stage the tumour at the same time, so you're not raising expectations. And in the event of the pandemic, we've been talking to various commercial partners to say, could we do this with the rapid diagnostic services, that we would set up a cool site or a COVID safe site that we could stage the host and the tumour at the same time. So where are we? So there's a lack of evidence of multimodal prehabilitation. We've talked to NHS England, the national team and the CCGs. They will not commission this without the evidence, but they don't really know what evidence they want. So we're funded for SafeFit for 2 years, and we're going to work together with the commissioners to be able to gain the evidence and hopefully then commission this within 2 years. The evidence effectiveness of exercise is the strongest. Preoperative nutrition support has been there for 20 odd years, but not really used in prehabilitation, and psychological and behavioural changes are emerging. There's big international and national trials we'll be reporting in the next 2 to 5 years. Personalised care and long-term plan is helping our case to some extent, but there's an awful lot of work to do. Some people have said to me that it must be really simple just to get your personal trainers to do this. But you've probably seen from the rigour, the stress, the anxiety and the complexity of SafeFit that we had to look at all of the rigour behind how we could underpin this with safe delivery of the interventions and with a robust infrastructure. With Mike Grocott as my co-I and Denny Levitt as our principal investigator, we know we're in safe hands, but it has been extremely challenging. I'd like to thank my huge amount of acknowledgements for where we are today, that we have got support from Macmillan, the Royal College of Anaesthetists, Wessex Cancer Alliance, Centre Perioperative Care, and the list goes on for SafeFit. And there are the contact details. Thank you very much.
Thank you so much for that, Sandy. It was just incredible. I think being able to step up SafeFit during a pandemic is absolutely amazing and so important to the patients. So, the feedback that you've got from that is just, it stands out. A few questions that have come through. One of the questions that's come up a couple of times is how did, so quite a lot of your patients are probably quite older. How did they get on with the technology, and did you need to help them out with that?
Great question. So we actually are able to just ring them up. But we have had a look at our demographic, and so far predominantly breast, so they are middle-aged, middle-class women, so we really need to address that in future, which we have plans to do. But no, actually we haven't had any issues with it. Quite a lot of people, even the older people, have got the technology to be able to do this, and even just ringing people up over the phone is support for them enough.
That's really good. I think Johnny's got a question that he's going to ask directly.
Hi, Johnny.
Hi there, Sandy. Yeah, fantastic. As I said, I'd just like to echo Sam's point about how you've managed to set up and adapt your very rigorous Westfit trial into SafeFit during the pandemic is fantastic, and particularly those preliminary monetary savings that you mentioned on the slide was pretty remarkable. Do you find that there's similar uptake and enthusiasm for SafeFit as there was for WESFIT from the patients?
I think the short answer is that SafeFit, we've just been inundated and we cannot keep up with the self-referral. I think it's probably biased because we're in a COVID era and pandemic. So the recruitment to SafeFit has been significantly easier than it was for WESFIT. And I do think a future service is a hybrid, and perhaps we need to look at SafeFit as being more the model, and WESFIT would be for people that are higher up the triangle. But great question, Johnny, thank you.
Fantastic, thank you very much. So thank you, Sandy, for that great first presentation. We're now going to move on to our second presenter. Now I have the pleasure of introducing Mike Swartz. He is a consultant in anaesthesia, critical care and perioperative medicine at Torbay Hospital at Torquay in the UK. He has spent his career developing shared decision making, the assessment of the high-risk surgical patient, and optimizing high-risk surgical patients before surgery, in addition to providing them optimal post-operative care. So I'm now going to hand the stage over to Mike. Thank you, Mike. Okay, I'll just make sure that you've got that. You've got the power mic. I think you just need to unmute yourself, Mike. I'm just trying to do that for yourself.
No,
there we go.
You hear me?
Yeah. Thank you,
John. I was going to say thank you for inviting me to talk, Johnny. But it's nice to be unmuted, and thank you, Sam. Good morning, everyone. It's a great pleasure to deliver this webinar. I was asked to talk about preoperative assessment. And I will talk about that, but I'm going to try and broaden it. Next slide, please. So what I'm going to try and do is give a sort of personal view of things that I've been involved in around perioperative medicine over the last 6 months during COVID, and the sort of information or experience that come from things that have been going on at the Royal College of Anaesthetists Council, things that have been going on with Getting It Right First Time, and also the Centre for Perioperative Care. Next slide, please. I'm going to start with the College of Anaesthetists. I like putting pictures into my talks, and I was trying to think of what would be appropriate for COVID. And I think these reflect some of the things that are probably emotions that we've been going through over the last 6 months. Next slide. I'm going to also though try and talk about positive things. And I think this is one of the big positives that have come out of COVID. You see at the top, you've got the Intensive Care Society, Association of Anaesthetists, Faculty of Intensive Care Medicine, and Royal College of Anaesthetists. Now, I'm a member of all 4 of those organisations and have been for a very long time. My experience of the 4 organisations is, while they're polite to each other to their face, they represent different factions and have slightly different behaviours and attitudes. But as soon as COVID started, all 4 organisations came together to set up a combined website where they would jointly post information about COVID and its management. And I'd be interested if you don't say you have to ask me questions about that. It'd be interesting to see if this was found to be a useful website or it wasn't a useful website to you over the last few months. Hopefully, the bringing together of the 4 organisations in a constructive way will carry on into the future. Next slide. I was a bit frightened to talk about exams. I'm not an expert on them, or actually I am an expert. I'm an expert in failing them, but I'm not an expert in the setting up or the running of the examination system. It's clear the exams have to carry on, but we have a problem. All the colleges have signed up to accompany Test and Reach for doing written exams. And I think that's going to work, although I'll comment in a moment about that. And I don't quite understand it, but they call it remote proctorship. I think this is where, while you're doing the exam, the camera on your computer can be viewed by somebody to check, are you exhibiting behaviours that may be associated with cheating. I certainly remember as a trainee, I didn't believe this, that the exams are cost neutral, but I can assure you they are. I've seen the books. They don't make money. They're very expensive to run. And it's things like the number of examiners you need, their accommodation, travel, and so on, and the organisation within the college to do exams. Unfortunately, Test and Reach is expensive, and it's not going to save them any money. The next two things I want to say are my personal view, and they haven't been decided by the colleges or the Faculty of Intensive Care Medicine and so on. They haven't finalised how they're going to do vivas or oral exams, but my expectation is it may be by some form of teleconference. What they're struggling with, though, is the OSCEs. And this is now just a personal view, and I'm not representing the college with this statement. I don't understand why you have OSCEs in exams. I would have thought that's part of your core training and should be delivered locally on simulators and should be part of the training process, not an examination process. But that's a personal view. Final bit on exams, the first one didn't go perfectly well. On the 28th of August, they did a primary FRCA MCQ, and there were problems with people logging on or being cut out during the exam. I think they were able to know how long people were logged out, and I think they were able to give people additional time so that overall you had the right amount of time for the exam. One thing I will say is it generated a huge amount of email traffic and was a big concern of your college council. And I think, you know, we all remember what exams were like. They're experiences you don't forget. And we can't have electronic examination that doesn't work or increases the stress of people doing exams. Next slide, please. Also, I'd like to draw your attention to the College of Anaesthetists QI Compendium, which came out this month. It's on their website, and they're holding a webinar launch that you can log on for free. I think it's the 24th of September. It's got about, I think, 15 different chapters. The first one is on preoperative care, but useful sources for if you want to do QI programs to improve your training and your CV. Next slide, please. So now the preoperative assessment landscape, and I don't think I'm going to say anything that you don't know in the next slide, please. You know, no surgery meant no pre-assessment. You know, the clinics closed down, the staff were moved appropriately to other parts in the hospital. Unfortunately, now that we've tried to restart surgery, we've got COVID chaos in patients not being pre-assessed, or you know, everything's just harder. You know, things that just worked don't work. So obtaining, and you know, you think you've got a pre-assessment patient who needs an echo, so you book an echo, but you don't realise that there isn't an echo available. So things that we had, we now don't have, and we don't know what's working and what isn't. Yes, we've moved to telephone pre-assessment and attend anywhere as the NHS telemedicine source. It works if you're fit and well. It works if you're the high volume, low risk patients. But I'm not finding it very helpful, or I'm struggling with it for high risk patients. Cardiopulmonary exercise testing stopped. There's guidance from poets on how to safely do this in times of COVID. I think most of us are starting back up, but we're limiting the number of tests we're doing, or we're being more cautious about, is this really going to make a difference to decision making? One thing I have struggled with is we have a perioperative medicine clinic where we see high risk patients, and I tried doing it by telemedicine and I can't. I need to have the response from the patient, from their face, from their body language, to help guide me in what I say. Equally, I'm struggling with face masks when you've got face-to-face consultations, and what we tend to do now is distance 1 to 2 meters, and then if patients are happy, we ask them would they like to take their mask off, and usually at that point there's a huge sigh of relief. I hadn't realized how much we use changes in people's faces to guide what we say. Certainly things are going to change for the long term, and probably the biggest change will be for low risk, high volume, a lot of telephone assessment. Next slide, please. So now moving on to GIRFT. A brief summary of what is GIRFT. GIRFT stands for Getting It Right First Time. And it started with Tim Briggs, a professor of orthopaedic surgery at the Royal National Orthopaedic Hospital in Stanmore. And when he was president of the Orthopaedic OAS, the orthopaedic equivalent of the Association of Anaesthetists, he teamed up with an epidemiologist called Muir Gray from Oxford. And he started to look at variation in practice within orthopedics. Now, this had been done before, but nothing really came of it. And the difference that Tim Briggs brought was he went as a clinician visiting hospitals to speak to other clinicians to talk about their data on things like length of stay, readmission rates, what procedures were being done. And from it has grown a sort of an improvement program that crosses about 40 specialties, one of which was anesthesia and perioperative medicine. And myself and Chris Snowden up in Newcastle are the national clinical leads for GIRFT, anesthesia and perioperative medicine. Next slide, please. Now, usually in August, all the meetings stop. It's a downtime. You never hold a meeting in August because so many people are away. Well, this August was different. The meetings continued, and in fact, they increased. Now, the big problem is we've got a huge backlog of elective surgery, you know, so big that the bombastic Mr. Johnson wouldn't be able to describe it. And it consists of a large volume, but also many thousands who've now been waiting over a year. At the same time, we've still got the disruption of COVID, and we probably will have more disruption. So starting in London, GIRFT has started to look at developing surgical pathways for high volume surgery. And I think in about 2-3 weeks, we developed about 30 pathways. Also, there is a move to, starting within London, to set up what are called hubs. Now, effectively, these are turning some of the hospitals or part of the hospitals in London into large day units, eye units, or orthopedic units. And the expectation is what happens in London will then be rolled out to other equivalents of strategic health authorities. And there's a big possibility here that we will improve the care of surgical patients, both before, during, and after surgery by doing this. We're also looking at, actually I'm going to jump down to model hospital. The other thing that's improved is model hospital, which is worth having a look at. You can Google it and get access to it if you register through as a doctor in the NHS. Now, model hospital's a bit complicated, but within it are data that tell you about your day surgery rates, your length of stay, your readmissions. Now, this with the pathways, I think, is going to drive up standards of care. Jumping back up my slide, I'm going to go to GIRF COVID-19 deep dives. Also within GIRF, there's a small group of us who are looking at outcome data of basically mortality, hospital mortality from COVID-19 related to the number of COVID-19 admissions per hospital. And what's reassuring in the data that we've seen is there isn't much variation in mortality. If you look at sort of 3 standard deviations from a mean, all the hospitals are really within that. There's a small number just on the line, both good and bad. And interestingly, some of the ones that were good, there are almost positive outliers in terms of less deaths. So places like Leicester and Luton, which I thought was interesting. What we're going to do with this data is we're going to start having teleconferences with the hospitals, and there's going to be representation from anaesthesia, intensive care, acute medicine, respiratory medicine, and so on. And we've got a whole series of questions to ask about what went well and what went less well. And what we're hoping to do from that is to come up with a report that gives people information on what went well, what didn't go well. And I think it's going to be largely, apart from the number of deaths, a positive report. Also coming up is the GIRF Anaesthesia and Perioperative Medicine report, which is out to stakeholders, but I think hopefully will be out by October. And then finally, before COVID started, we had a group from the British Association of Day Surgery, that's BAD, the Centre for Perioperative Care, that were looking at a day surgery best practice guide. And in July and August, we reformed that group and have produced a day surgery guide on how to do day surgery based on the national experts within the UK. Next slide, please. Now, within that document, it may seem strange, but it starts with defining what a day case is, because not everybody's working to the same. And the ideal day case definition is you are put on a day case pathway and you succeed to be a day case. It's not 23-hour stay. It's important to get your staffing right. It needs leadership, that's medical leadership, nursing leadership, and managerial leadership. We've got lots of examples of good pathways from what are regarded as the most successful day surgery units. It's clear that actually having dedicated day surgery facilities and a day surgery team works better than trying to put day cases through an inpatient pathway. The better units are using information technology. By that I mean electronic pre-assessment records and anaesthetic records, and using that to gather data to improve their processes. There are some metrics you should be recording. You know, all patients should be followed up with a telephone call to assess nausea, vomiting, pain, and patient satisfaction. It's clear that we're going to continue to have problems with COVID, and we're going to have to create, I don't know if we're allowed to call them this, red and green hospitals, or what colours or names we're using, but we're going to have to separate patients with COVID from patients who don't have COVID to do day surgery. Next slide, please. Within the document is a pathway. I think the main bit I'd like to say about this pathway is all the things that are in the dashed black line box, that's day surgery. Surgery is a small component of day surgery. What we're struggling a bit with is to get surgeons to understand that. An awful lot of the GIRF time so far has been focusing on getting the surgeons to agree. We need to set up some day surgery teams within London, and we only just found out where the potential hospitals will be, but that's the thing for the next few weeks. Next slide, please. Other parts of the process, I'm not going to go through all of this, but there's an awful lot that needs to be done for this to be successful. And I think unless the day surgery processes of part of the pathways are working, what is going on in London is going to fail. Yes, you need to get the surgeons to agree that they will work to a common pathway and they will have pooled lists. And we're talking also about doctors moving to work in different hospitals and having like your STP passport. That means you don't just work in one hospital within your STP. You will have to go to where the patients are. I think actually COVID has, I don't want to say helped, but it's allowed change to proceed at a more rapid pace. And I think it's also allowed people to go, you have to do this. We can't just work the way we used to work, because it wasn't working then, or it wasn't optimally working then. And it's going to really struggle to get rid of the backlog of patients. Next slide, please. Again, I'm not going to go through this, but I'm making the assumption you've got access to these slides for more detailed reading. This comes from the BAD CPOC GIRF National Day Surgery Delivery Pack, which, as I say, hasn't been finalised, but I'm pretty certain this won't change. And it should be out in the next 2 weeks. But that's the sort of checklist that goes, if you're going to do day surgery, that's how you have to do it. And I think there's a huge potential for improving patient care with this becoming a sort of mandated, this is how you do day surgery. Next slide, please. So finally, pulling in a bit of CPOC, or Centre for Perioperative Care. Next slide. Having said that, this document, while it involved CPOC and College of Surgeons, College of Physicians, is a Faculty of Intensive Care Medicine document. In May, well, it was ready to go back in March, but we delayed the launch of it because it probably wasn't the right time in March. But this document sets out the standards, or the principles rather, of providing what's now called enhanced care. I used to call this level 1.5, or some people call it level 1+ care, meaning it was something between level 1, which was ward care with critical care support, versus level 2 care, which was HDU on a critical care unit. And what this is about is providing things that are not available currently on a ward, but that patients may benefit from. For example, access to a vasopressor, or drugs to treat atrial fibrillation like amiodarone or magnesium sulfate, access to arterial lines and blood gases, a slightly higher nurse to patient ratio than on the standard ward. Now that came out in May 2020 as a document of how to do it, and it's on the FICM website. Next slide. What's also happened though since that document came out is thoughts on, so what do we need to do to cope with potentially further COVID outbreaks of need for intensive care, and also to get rid of the backlog of high-risk surgical patients? So the thoughts were, do we need more level 3 ITU beds? Well, yes, if we had what happened in March and April, but otherwise in normal times, our shortage is not so much intensive care beds, it's more HDU beds. So the next thought is a level 2 HDU bed in an ITU or a postoperative anaesthetic care unit the answer? And again, probably no, it's not the right place to do the care. So to fix these things, let's use the lessons we learned from COVID. We were able to almost double intensive care capacity in the UK by using anaesthetists, ODPs, theatre nurses, surgeons, all our staff. So how do we keep that? And what may be coming soon, I put a question mark to it, is there's been a group within FICM, CPOC, NHS England that have been preparing a statement on enhanced care that I hope will come out in the next few weeks and will be more didactic about what you have to do, rather than the first FICM document on enhanced care, which is a bit fluffy. The big question is, where's the money for this? And that's an unknown at the moment. And more importantly, where are the staff? But the concept of the staff who will do this is you won't be from one background. You could be from any background. And it will be more about teaching and training you to be competent to deliver the care, not do you need to have a 2-year ITU course and a nursing degree, which you need to do to get into a nurse into a level 2 or a level 3 unit. I think I'm nearly done. Next slide, please. Yes, so my final slide is, what do patients need? I think they need enhanced care, and I think they need enhanced recovery. And what we need to do now is plan this around patients, not around doctors and nurses, which is what we normally do. Next slide, and thank you very much.
Thank you very much. Really interesting. I think the point that you made about COVID being able to enact more rapid change within the NHS is quite pertinent. So thank you for that. I've got a couple of questions coming in. I think in the interest of time, I might just try and keep it to one question. One that's coming, I'll just read it here. Thank you for your insightful thoughts on the state of play in the wake of COVID, particularly the need for face-to-face for high-risk shared decision-making. What do you think the challenges might be, exams aside, for trainees balancing service delivery and training across red and green sites?
I feel like answering by saying I don't know. I think the question is the answer. It's just putting it in the open that we have to continue to deliver training, and we have to continue to deliver patient care. I think when the COVID really kicked off, we did exclude trainees, particularly in anaesthesia and intensive care, from certain procedures because of, say, for intubation. I think the PPE worked. The people who caught COVID who are healthcare workers were predominantly not anaesthetists and intensive care staff. They were people on the ward. So I think we need to bring back trainees to all clinical practice and use the right PPE and not stop the training, whether it's on a red site or a green site.
Perfect, thank you so much. I think in the interest of time, we're just going to move on to the next speaker. So I'll hand back to Johnny there. Thank you very much.
Thank you, Mike. Fantastic presentation. And now on to our last presentation, which will be delivered by Dr. Ramai Santhirapala. She is a consultant anaesthetist and perioperative medicine lead at Guy's and St Thomas's NHS Foundation Trust. She is currently the clinical lead for the UK arm of an international programme in shared decision-making called Choosing Wisely, and is hence the perfect expert speaker to deliver our next talk, Surgical Decision-Making. Over to you, Ramai.
Thanks very much, Johnny, for that kind introduction. So as you heard, I'm a consultant anaesthetist, I'm the perioperative medicine lead, and I have several kind of national and trust-based roles. But really the question is, who am I? So I'm a Sri Lankan-born Tamil who came to London as a young child via Nigeria, and I've got significant influence from California and Hawaii. Why am I telling you this? Because it affects my values, it affects my preferences. I wanted to take you on a little story. So not unusually, I do find myself, unfortunately, in Hawaii. Obviously, family is important to me, and on waterfall hikes. This is a picture on your left of Pali High Twin Falls in Oahu, Hawaii. Obviously, with the lockdown, it means that none of us can really travel, and I thought it was safer to go to West Wales this time, to a place near Pembryn, and went to this specific waterfall. Had a slightly different outcome this time. So I managed to get through the bit that needed careful footing, and I was on the kind of straight path to the waterfall when I missed my footing, went straight down onto my left hand, which I'm left hand dominant, and I'm also hypermobile, so I managed to hyperextend and I got a volar plate avulsion fracture. So during Sandy and Mike's talk, I was doing physiotherapy under the table. I went to healthcare provider 1, and healthcare provider 1 suggested that I needed urgent surgery. So I was listed onto the trauma list. Now, just to give context, obviously it's you know, a fairly kind of, it's a minor injury, albeit it's in my dominant hand and my fragment has actually rotated. But this isn't a cancer diagnosis, and I'm not facing major surgery. However, I felt a little bit in shock. I felt that I had a lot to process. I suddenly was being told the risks and benefits of surgery, and I had my COVID swab, obviously. And then we were talking about kind of signing the informed consent form. And given what we all do in our professional capacity and also the work that I do within SDM, I knew I had to press pause. So I kindly asked the plastic surgeon, who is fantastic, how long I had to think about this. And they said, well, you've got a 10-day window in which to have this surgery if you do proceed, so go away and have a think. I went and got a second opinion at a second healthcare provider, and they had a dynamic x-ray, so they were able to see how the fragment moved around when I flexed and extended my finger. And they said, you know, given that you're a motivated patient, I think we can get away with intensive physiotherapy. Urgent surgery is still on the table, but also if it doesn't quite work, then there's also delayed surgery. So really what mattered to me, well, I'm a left-hander and I'm a very much a left-hander. Obviously, as an anaesthetist, a laryngoscope is a left-handed instrument, and also I do all my procedures with my left hand. So, you know, from a clinical practice perspective, it's really important that I have a good functional outcome. Very recently, we started playing the veena, which is a South Indian musical instrument, also needs both hands. And as some of you might know, I'm a yoga enthusiast. So I want a good functional outcome, and I want to get back to doing things that I love. So who decides whether to operate or not? Well, this was the subject of an editorial that I was grateful to write. It was published in January, just pre-COVID, and it was alongside my colleague Judith Partridge, who's a consultant geriatrician at Guy's and St Thomas's, and also Karen McEwen, who's a surgeon. And really in this, we speak about the complexity, the increasing complexity that we face, particularly in the older surgical patient. Obviously, I'm not quite there yet. And we speak a lot about risk and about risk assessment, risk stratification, and also the optimization. So Sandy spoke about the Rubik's Cube, because we can modify so many of those risks through optimization and prehabilitation. But also that the complexity of these conversations needs some level of communication skills and sensitivity. And we also need to learn that as clinicians, we can be vulnerable both with each other within a professional community, but also with patients. Sometimes we don't know, and we need to be able to acknowledge and manage that uncertainty. So there's a spectrum of choice that we can take patients under. So for example, I could have gone with the provider 1 option and said, right, doctor knows best, I'll list myself for surgery. Or I could have gone and done a Google search, or in many of us, what I actually did was a PubMed search on volar plate fractures. But actually, most of us would want to go down a shared decision-making route. So I wanted the clinical expertise of my plastic surgeons. I wanted to know what they thought was best, but I wanted to then decide based on my values. So definition of shared decision making, this is the one that I most frequently use, is from the King's Fund, and it's clinicians and patients working together. And it's based on the best clinical evidence. So it doesn't strip us of professional autonomy. Like I said, I want clinical expertise when I'm a patient, but it's centered on our informed beliefs and preferences. But also there needs to be a certain amount of decision support counselling, and that's basically a posh way of saying that we need to be able to support patients in understanding what matters to them. Because, for example, I don't think it's apparent in one conversation to know what's important to me. And we need to be able to communicate that. So one thing that really meant a lot to me was that provider 1 and provider 2 talk to each other. And if you imagine in a high-risk surgical pathway how many interactions a patient has, and I think most of us who are anaesthetists on this call, if you just imagine sitting in your high-risk clinic and sometimes how frustrating it is not knowing what's been said to the patient upstream and not knowing where to start that conversation from. So why deliver shared decision-making? This is kind of the theoretical bit. Well, it's the very heart of something known as value-based healthcare, which Sandy also touched upon, and it's really centering patients in personalising care. And this improves the quality of the care that they get. And I can't tell you that it's going to reduce POM scores or that it's going to reduce Clavin-Dindo scores just yet, but what I can tell you is it will help your patient-reported markers. So it improves patients' confidence, for example, or improves their engagement in healthcare. And there's potentially also a cost benefit as well. How I like to think about shared decision-making is I use the IHI's quadruple aim framework. So I think it touches on all those parts. And that essentially says that it improves patient experience. And we know this from the data. This is CQC data. So it's our kind of national governing body or regulatory body for all our hospitals. And every year it asks a survey in which one question is, were you involved in decisions as much as you wanted to be? And as you can see, consistently over a decade, that 50 to 60% of patients say yes, but actually there's a huge room for improvement. Similarly, like I said, I can't tell you about the kind of clinician reported and the process markers just yet. We need that evidence to come in, but what I can tell you is it improves your patient's confidence, improves their engagement, improves their compliance to therapy. And what is interesting about these Cochrane reviews, so Cochrane regularly reviews on shared decision making, is that actually when you're looking at major surgical interventions, patients want less than more. So actually Cochrane report that actually up to a reduction of 16% in major surgical interventions just with SDM, and that's with a fully informed patient. And this is the last thing around workforce experience, and I feel really passionate about this. This is actually what drew me into shared decision making, is that morning of surgery, when you meet a patient, particularly a high-risk patient going in for a major intervention, and you have that heart sink moment and you think, my goodness, I don't know if this patient's informed, I don't know if they understand their risk completely, and I don't know if this is in their patient's best interest. And I had this a lot as a registrar, and you know, I'd like virtual hands up if you've had the same experience. And really, I just came to the point that I thought, I can't work in a system like this, I need to do something about it. And now we've got a name for it, it's called moral injury, and it's when you act against your moral compass as a healthcare professional, and we know that it leads to burnout. And really what we need to do is create this psychological safety, so this safe space. So Mike Swartz spoke about his amazing high-risk shared decision-making clinics, and I know that they're MDM, and I'm still waiting to get down to Torbay, perhaps you know, post this pandemic. But really we need that kind of safe space that we can be vulnerable with each other, saying actually, particularly for the specialist services or the kind of specialist patients, that we need that openness to speak about this, quite frankly. Is it cost effective? I can't hand on heart tell you in perioperative care that the data is there, but it makes logical sense. It might need some upfront cost, but actually what you're doing is you're improving your efficiency and your utilization. So who is the shared decision-making team? So traditionally, the mindset is that shared decision-making is this one-stop intervention that happens between a clinician and patient, and clearly that's not correct. It's an iterative process. So right from when the GP refers a patient into secondary care, so usually a surgical outpatient at Guy's and St Thomas's, that process of information starts, and that process of shared decision-making should start from that factor. And the reason being is it takes time to consider your options, and it takes time to understand what's important to you in the context of what you're faced with. And I can tell you as a patient now that that's certainly true. So it's much bigger than a one-stop clinic appointment. It's actually an iterative process right down the perioperative pathway. And the patient has a team. So I didn't make a decision about what to do without consulting family members, friends, and also because of what we do, we have kind of expert colleagues. But we did 57 semi-structured interviews at Guy's and St Thomas's, and we found that patients, came back to us with, we ask our family, friends, neighbours, we use the media, we use the internet, and then there's medical professionals. So I think, let's not overplay what the implications. Obviously, our professional expertise is really important, but there's a much wider source of information coming into that patient. And obviously, we should be working in perioperative care teams. Now, what I can clearly see is where the MDT works effectively, there's high quality shared decision making going on. Where the MDT is maybe not as functional, there is not high quality shared decision making. So we should be working, so at Guy's and St Thomas's, it's surgeons, anaesthetists, physicians, geriatricians, working closely together, but also kind of with our nursing colleagues and our allied health professionals. So for example, the physiotherapists have been fantastic in our MSK pathways, for example. But also my view is that we can do as many grassroots pilots as possible, but actually we need some level of kind of executive buy-in and national endorsement. And I was really lucky with the work at Guy's and St Thomas's, which I'll present shortly, that I had the support of our immediate past Deputy Chief Exec, so Dame Eileen Sills, who you see to your left. But also at a national level, this is something that the immediate past Chair, Carrie McEwen, of the Academy of Medical Royal College has felt really passionate about. And I think, that synergy is coming together. And I think, as Mike has said, COVID has just accelerated what was there already. So a little bit about the national and international agenda. So the NHS England is going to be launching the Personalised Care Institute next Tuesday. So that's very much a focus on personalised care, including shared decision making. NICE have been working within the sphere of shared decision making in the form of a collaborative for several years now, but they'll be bringing out guidance in 2021. It's going out for consultation in December, so if you're interested, get in touch so you can be part of that process. The Academy of Medical Royal Colleges are doing it through the initiative Choosing Wisely, which I'll go into very shortly, and it's also a key theme for the Centre of Perioperative Care as well. Just briefly about Choosing Wisely, the Choosing Wisely was an initiative that's solely centered on how we improve conversations in healthcare. It doesn't have any other kind of agenda behind it. Started off in the States in 2012 and it's now swept over 22 countries, of which 5 you can see here. And these are the kind of 5 that work very closely together with the, I guess, Western nations in inverted commas. So Choosing Wisely UK was launched in 2016. And the first step is to develop recommendations, particularly around low-value procedures and shared decision-making. And this is an editorial if you want to read about the process that we did initially. But really the heart of the UK initiative was promoting, or is promoting, an acronym known as BRAND. So what are the benefits, what are the risks, what are the alternatives, and what if I do nothing? And we found that this is actually a really useful structure for consultations from a professional perspective, but this actually came from patients, and patients said, I want something really simple that I can just think of on the day and go through with my clinician. Again, this is another editorial if you're keen to have a read. But then came COVID. So we know that COVID has particularly complicated the risk conversation. This is a result from COVID surge, which was published in The Lancet. An impressive study given there was a global pandemic going on concurrently. I know there's been a lot of criticism around the timing of it per se, but what it found was that a perioperative diagnosis of COVID-19 increased your 30-day mortality and increased particularly your pulmonary complication rate. So of course that's increased the complexity of the conversations that we're having. So what have we done to pilot Choosing Wisely at Guy's and St Thomas's? So this was all pre-pandemic, and I'll go through our aspirations going forward. So like I said, the first thing I felt was important was executive buy-in. So I approached our immediate past Deputy Chief Exec, and thankfully our present Deputy Chief Exec is also very keen on this, and we developed a Choosing Wisely steering group. We put a call out to pilots, and this was actually across all directorates, but interesting, the 3 that answered were all perioperative, which is quite handy. We looked at the total knee pathway, so leading to total knee replacements. We looked at skin cancer MDM, where they looked at limited versus more extensive resections of skin cancers, and the POP service, the preoperative medicine for the older surgical patients, which was across several surgical specialties. We also had a patient information and awareness campaign and a staff campaign underlying it. So this has been running for about 12 months and paused immediately post pre-pandemic. First of all, it's to understand the baseline. Now there's a lot of academic tools about how you measure shared decision making. The more nuanced or sensitive ones are very labor intensive. They might even involve a video or someone interpreting kind of consultations. And really with kind of the work that I do nationally, I really wanted to implement a program that people anywhere could implement in their local setting. I didn't want to make it difficult. So we went with the SDM Q9, which interesting NHSE are also going to be recommending through the Personalised Care Institute. So this is a paired questionnaire. So for each consultation, a patient will get a questionnaire and a clinician will get a questionnaire for the same consultation. And it touches on 9 aspects of shared decision making, hence SDM Q9. And for each aspect, it asks patients and clinicians to rate from on a 6-point Likert from completely agree to completely disagree. These are some results from our orthopedic cohort. So this represents 26 orthopedic consultations. The dark blue represents where the orthopedic surgeons completely agree that they hit the 9 parameters that you see to your right. And the yellow is where they agree strongly. As you can see, a huge amount of confidence in our orthopedic cohort that shared decision making was already happening. Similarly, our patient scores, I mean, our patients are very kind to us at Guy's and St Thomas's, and a huge amount of satisfaction. So again, blue is agree completely and yellow is agree strongly. The other thing we did was we process mapped the pathways. Now you can imagine for some of our more complex pathways, this is messy. This is one of our inverted commas simpler pathways in a simplified process map. But I think process mapping is really important because it helps you to really distinctly see where shared decision making is happening at the moment. So particularly as an anaesthetist, and I know our geriatrician colleagues at Guy's and St Thomas's will agree, is that quite often, you know, quite late in the pathway, patients are still having inadequate shared decision making. So there's by that time they're pretty much psychologically committed to surgery. So then you have to do that reversal. So much of the frustration that I said that you find when you see a patient on the day. So really kind of a lot of our work is training kind of our physiotherapists and also moving this upstream. So our surgical colleagues start to support that brand conversation. It also really highlighted really small nuanced QI projects that you could do to help surgical decision making. So for example, we identified that our orthopedic vetting process wasn't particularly robust, so a lot of inappropriate, and I mean kind of inappropriate in the sense that surgery shouldn't be on the table in the first place, were making it to orthopedic outpatients because the vetting process wasn't quite robust. And similarly, the way we did radiological investigations meant it cut in on clinic time, which means our orthopedic surgeons were very rushed in their already kind of 10-minute slots. So just identified small things that you can do to help the process flow smoother. The other aspect that's really important is stakeholder engagement. So this is not just with clinicians, so kind of anaesthetists, geriatricians, surgeons, but also I think it's really important to involve middle management, so all kind of managerial transformation leads, etc., as well as your allied health professional colleagues. And this is some of the comments we got, that you know they wanted a standardized process, and hence brand fulfills that. That clinicians obviously still feel under pressure, even more so now post-pandemic, and they wanted patients to be prepared and greater expectation management before actually seeing them, so upstream in the pathways. Similarly, I mentioned before that we did 57 semi-structured interviews, and again our patients said, you know, there's still that power imbalance and they still feel that they can't speak up or advocate for their kind of values. So it'd be really good if clinicians can start that conversation, or the relevant healthcare professional. They wanted information leaflets upstream, but they also wanted prompts on the day, because no matter how much they prepared, they still felt anxious on the day. Through all that kind of stakeholder and some national endorsement, we developed these brand patient-facing leaflets. Now, these go out ahead of the MCATS appointments, ahead of the orthopaedic outpatients, so very much ahead of any secondary care intervention. And the same goes for our proactive care and perioperative medicine for the older surgical patient service, and also for our skin cancer MDM. So it goes out ahead of those secondary care consultations. This was thankfully nationally endorsed, and we also have the endorsement of NHS England on this as well. And really what it does is it allows patients time to think through their brand and hopefully through their individual values ahead of that consultation. So like I said, it's very important that we give patients the time that they need to process all this. There's also education and training. So we've been running workshops for just over 18 months. We've been really lucky. We've got Alf Collins, who's one of the co-leads on the Personalised Care Institute at NHS England, also a former anaesthetist, helpfully. And we also, literally weeks before the pandemic, were really delighted to welcome Professor Angela Bader from Brigham and Women's Harvard Medical School. So these workshops take the form of a plenary, and then what we do is we go onto videos, and then we do some role plays. And actually one of my other photos has our distinguished speaker, Mike Swart, on it as well. We measured the kind of confidence in shared decision making before and after, and as you can see in all aspects of shared decision making, the participants say that their confidence goes up. But actually it was more the qualitative analysis that was really telling. A lot of patients turned up to these workshops and said, I don't really know why I'm here, I do shared decision making already, I don't think I can improve. But then once they actually find out what it's all about, their opinions change very quickly. We supported these with some e-learning that we've developed, and this is at an international scale. So this is e-learning that's developed by the Academy of Medical Royal Colleges alongside the Australian Commission for Quality and Safety in Healthcare and the Winton Centre for Risk and Evidence Communication. These are free, anyone can create a login. They only take 2 hours, and I think they're a brilliant introduction to shared decision making. We've just had a paper accepted in the BMJ, where we'll be going through our initial analysis of these e-learning programs. But also documentation is really important. So our perioperative medicine for the older surgical patient, they came up with this great little documentation tool that they added to their POPS letters so that they could actually document what they run through patients with respect to brand. Also, what's important is actually it's not so much our clinician understanding of what's being relayed, but also our patient's understanding. So we know from the shared decision making literature, there's a lot of perception imbalance. So, you know, a clinician will walk away from a consultation and say, yes, I said X, Y, and Z, and the patient will come away with a completely different perception. So we've developed this kind of national tool to document multidisciplinary shared decision making. So back to kind of brand. So my specific scenario, what was going through my head as I was trying to navigate what to do with this finger fracture? Well, I know that going ahead with surgery is going to give me a good radiological outcome and potentially a good functional outcome. I had to say, you know, like I said, the kind of fracture piece is actually rotated, so I've got articular edges against cartilage. So from that perspective, provider one thought that was really important. There are risks, so it involves an operative risk of a 4-centimetre incision into my finger. They obviously have to go through tendons, obviously not transect them, but put them aside. And then they have to find a 2mm fracture piece, turn it round so the articular edges are opposed. And then because it's too small for a screw or for K-wire, they then have to tack it with some vicryl sutures. I'm thankfully a low perioperative medicine, low perioperative risk. So other than some iron deficiency anemia, because I'm vegetarian and a woman, which is controversial right now, I know if I was facing major surgery, I'm relatively low perioperative risk. I'm obviously conscious of the COVID risk. I'm in London. London got hit hard with COVID-19. I would be done as a day case. The alternatives are intensive physiotherapy, and obviously to do nothing is natural healing. It was interesting, my radiographer at one of the providers actually said, oh, back in my day, you know, we didn't do anything about this, and I just had a crooked finger, and he was showing me his kind of functional deformment. I've decided to go with physiotherapy. I'm a motivated patient, but also I don't really care about radiological outcome. I want a really good functional outcome. So whatever gets my left hand back to where it was will suit me just fine. And I don't mind if I don't have a pretty x-ray. So some take-home messages on that is, you know, start learning about shared decision-making. So like I said, do the 2-hour module. Start in your organization. Now, COVID, I think, you know, more than anything, actually accelerates the pace at which SDM can be implemented. I think there's no more need than now. So, you know, simple things like executive buy-in and process mapping and measuring the baseline. And Mike mentioned the RCOA QI compendium, and actually on page 76, myself and Rupert Pearse have written a kind of suggested list of QI projects you can do to get started with SDM in your trust. And the brand resources I've mentioned are actually available from the CPOC website. So with that, I'll close and open to questions. Thank you very much.
Thank you so much, Ramai. I think we're not used to being patients as clinicians, are we? So it's really fascinating to sort of see the shared decision process from your perspective as a patient. I'm just going to sneak in probably one question. It's come up quite a few times, quite a few people have asked it in different ways. Talking about how you achieve shared decision making in the more emergency setting. So rather than the high risk clinics, how can we best prepare patients for shared decision making in a sort of emergency laparotomy or elderly trauma setting?
Yeah, so I think first of all we have to say that it's just as important in that setting as it is in elective. So we have to make it the standard of care. And I think this is really where BRAN interfaces. So I'll give you an example. Just a couple of months ago, I had this emergency laparotomy on ITU that needed to come back, and he was an elderly gentleman with hepatic metastasis, frail, elderly, and no one had, or from our understanding, it was also non-English speaking. So actually, when we actually had the conversation, it became really apparent that he wasn't aware of his risks. So I have to say that he was actually extubated and kind of returning from ITU as a repeat laparotomy. And, you know, I just made it as a consultant on call, and I just mandated that we have that conversation. So the surgeon, and luckily one of our registrars was Cantonese speaking, which matched his requirements, and we also had language line involved, and we had that MDT. And I have to say, it's just putting your foot down and making sure it's a standard of care. And obviously BRAN helps a lot, so being able to document the benefits, risks, alternatives, and doing nothing. He had a perioperative risk, a NELA risk of 36%, so it's incredibly high risk. So I think we just have to kind of bite the bullet and not accept anything less than kind of shared decision-making conversation.
Thank you so much. I'm going to hand back to Johnny now for closing.
Thank you, Sam, and thank you, Ramai, particularly for that personal insight and personal story. I think it adds a lot of strength to any presentation. A huge thank you to all the speakers from today for some fantastic talks. It's been really, really interesting to see it from all the different perspectives. And thank you, all you listeners and attendees, for letting us into your homes this morning and places of work on a Saturday morning. We really appreciate your company. It just remains for me to say we hope that you enjoyed today's webinar. Please do give us some feedback so we can develop the next 2 weeks of webinars, which we have running next Saturday morning and the following Saturday morning. And enjoy your weekends. Goodbye.
Did you guys want to do